Before our break, we discussed the mechanisms by which vasculitis occurs, how white blood cells traffic under normal circumstances, and what happens under abnormal circumstances when they become lodged within the vessel wall, dump their payload, and cause vascular injury. We also discussed the difference between primary and secondary forms of vasculitis and how important it is to distinguish those two, because the secondary forms have a known cause and have usually effective treatments. So what I'd like to focus on now are the primary idiopathic, presumed to be autoimmune forms of vasculitis. And let me start with a case, and this is sort of a large vessel vasculitis conundrum. So a real patient, all of these are real patients. In 1994, a lady living on the West Coast, age 32, feeling perfectly well at a routine history and physical, is found to have an asymptomatic aortic regurgitation murmur. She's followed over the years and nothing much is thought of this. In 2004, 10 years later, she has an echocardiogram done just to do a little more diligence, and the aortic root appears to be slightly dilated. A year later, it's repeated. Well, it's dilated a lot more. It's 5 centimeters now, but she feels well, and in fact is quite athletic and quite active. In 2006, there's further increase in this aortic aneurysm. She feels fine, but the recommendation is, because of the high risk of an aneurysm at 5.5 centimeters rupturing, dissecting, and causing sudden death, she is taken for an aortic valve replacement and an aortic root reconstruction. And at surgery, she is shown to have this very thick aortic wall, normally should be about 1.5 millimeters at the root. This is 10 millimeters, and under the microscope we see this intense inflammatory process. Her doctors know that among the causes of aortitis are infections, so the appropriate staining and cultures are done for organisms. None are found. She's tested for syphilis and tuberculosis, and that is negative. So she is thought of as perhaps having focal vasculitis, but we don't really know that for sure. Her doctors say, well, this is bad enough vasculitis, so we should treat you with very aggressive steroids and chemotherapeutic agents. And that at that point, because she feels well, she asks for referral to see us, and we get this MR, and we can see the area of the aortic root reconstruction, but the entire remainder of the vascular tree is totally normal. And so the question becomes, for us as well as for her referring doctors, should she be treated? Now, again, she feels well. She's post-op, recovered, and if you're going to treat her, are you going to treat her with prednisone and cyclophosphamide, prednisone and methotrexate, prednisone and mycophenolate, or perhaps you might even withhold medical therapy? She feels well, she really doesn't want to take anything. Are you just going to follow her along? Or are you going to think that maybe this has nothing to do with vasculitis, maybe this is a matrix disorder, maybe she has Marfan's or Ehlers-Danlos or Loeys-Dietz syndrome? So think about what your choice would be there. Our choice was not to treat her because we could not prove that she had disease beyond the surgical site, which was resected. And we did commit to following her very, very, very closely to be sure that new sites of disease did not develop in other territories. So we followed her now for over 6 years, and we keep imaging her every year, and there have been no new lesions. Her lab studies remain fine. She is fully functional, and she is an example of something you don't hear about very often, but it's not that uncommon, and that's single organ vasculitis, focal vasculitis, which lends itself to surgical resection and surgical cure. Now, single organ vasculitis is actually a very large literature. And from one of our papers here, you can see all of the different organs that have been reported to be the sites at which single organ vasculitis has occurred. And I give you a partial list here of those areas that are amenable to resection of that focal lesion. But I'd also remind you that there are some forms of single organ vasculitis that don't lend themselves to resection. And that would be, what if you had diffuse skin involvement? That would be a single organ, but you couldn't cut that out. What if you had vasculitis that was multifocal within your brain but limited to your brain? Well, you can't cut that out either. At least we don't do that. What if it was diffuse renal vasculitis? Can't cut that out either. Those are the forms of single organ vasculitis that require immunosuppressive anti-inflammatory therapy. So what I tell you about single organ vasculitis is if you make the diagnosis and you've done diligence and you've looked to be sure that there's no inflammation in any other site, that it's not part of a systemic disease, do not initiate corticosteroids if you are fairly sure that this is a focal, potentially surgically cured lesion. But I would also urge you to very carefully follow these patients to make sure that this was not the introduction that this patient has given you to telling you that they really have a systemic multifocal disease. So for the example for aortic arch vasculitis, we do image these people regularly. We will see them if they have any new symptoms whatsoever and make sure those new symptoms are not part of a multifocal systemic process. That actually occurs very, very infrequently. And again, to reinforce that this is not just an odd thing that we see here at the Cleveland Clinic, these are a number of references that talk about single organ vasculitis by other people and cite observations from many other centers. Now, when we speak about the more common forms of large vessel vasculitis, the two that we often think about are Takayasu's arteritis and giant cell arteritis of the elderly. And the question that I'd like to plant in your mind, even though I won't resolve it here today, is, are these the same or different diseases? So let's consider Takayasu's, a disease generally of young women, 9-to-1 females to male. And I'd like to make the point that while I've already told you that this is a large vessel disease, that there's so much more to taking care of these patients than just starting steroids or perhaps adding another immunosuppressive drug and treating the inflammation. You need absolutely to know in detail the anatomy of the vascular injuries that these people have had. So let me tell you what we've learned from our experience in regards to the issue of monitoring blood pressure. Monitoring blood pressure in these people is absolutely critical because many of them are hypertensive, and if their blood pressure is not controlled, they die of either hypertensive complications relating to stroke, heart disease, or renal failure. So put that now in the context of recognizing that this large vessel vasculitis produces stenoses of blood vessels 98% of the time, and aneurysms are less common. And that the subclavian and innominate vessels are almost always involved. And in almost 50% of cases, that would be bilateral. Also, in regard to hypertension, recognize that 40 to 80% of patients will have renal artery stenosis, the implication being renal ischemia, high renin hypertension, and a potential opportunity to cure hypertension surgically. So let's go to a question. We measure blood pressure by putting a cuff around the arm. What are we really wanting to know? We want to know what the aortic blood pressure is. Because it's the aortic blood pressure that's transmitted to the brain that affects cardiac function and renal function. But we can't put the cuff around the aorta, so we put it around the arm. So let's look at this patient's vascular lesions. Here we have a carotid, another carotid, a narrow subclavian, and an area of short dilatation of the right subclavian. So my question to you is, which extremity will be a reliable site for monitoring this patient's central aortic blood pressure? Is neither arm reliable? Is the right arm reliable, or the left? You don't get too much time to think about this one because it's pretty straightforward. So the answer is that the right arm is reliable. This slight area of dilatation is not going to dampen the pulse pressure from the heart going out to the aorta and subclavian. This is going to have a tremendous dampening effect in the blood pressure of the left arm. So the right arm is what you're going to use. Now, it gets worse than this in other patients. Now, look at this MRA, and I'm asking you now to quickly see if you can recognize what's wrong with this picture. Where is there abnormal blood flow? Where is there abnormal anatomy? So in the interest of time, I will tell you that this is the subclavian vein. It's not the subclavian artery, and you can see it emptying into the vena cava. There is no subclavian artery on this side. There is no subclavian artery on this side. You do see a lot of collaterals, but you don't see the subclavian artery. Now, the lower part here is a little more difficult to see, so we'll blow that up for you. And here you can see a striking right renal artery stenosis. You can also see narrowing of the abdominal aorta. Where's that left kidney? You don't see a left nephrogram. There's no dye being taken up in that kidney because that kidney is not only ischemic, but it's infarcted. But it's there. And so this patient raises the question of, how do I know what her blood pressure is, recognizing that she's a setup for very high renin hypertension because of a ischemic, infarcted left kidney, a ischemic right kidney, and abdominal aortic stenosis. And in fact, she has profound hypertension, and we found that out by measuring the blood pressure by catheter in her abdominal aorta. But our goal in doing that was to determine whether or not this narrowing actually produced a hemodynamic significant gradient. And fortunately for her, it didn't. So her legs were a reliable reference point for blood pressure monitoring. And her blood pressure was 240 over 160. And what she needed was a left nephrectomy because the renin from her left kidney was 10 times higher than from her right kidney, and that was in the plans. So when you see someone in whom no extremity or possibly one extremity may be a reliable source, but you don't know for sure, you actually have to do the invasive angiogram with blood pressure recordings. As we follow these people with Takayasu's, and this may be a strange sight for you, but these are the kind of patients we see, no subclavian here, no subclavian there. We follow the entire aorta and its branch vessels by MR imaging all the time because new lesions mean active disease and we're not adequately controlling it. So these people absolutely need to be followed by an imaging technique that includes the entire aorta and branch vessels. Now let's switch to giant cell arteritis, and again I'll go back to raising the question, the same or different than Takayasu's? Well, in some ways different, because these are elderly people. Takayasu's patients' average age is 26. These patients' average age is 74. These are people who are mostly European, North American, Caucasian, and again, like Takayasu's, there's a female predominance. When you look at GCA worldwide, Iceland and Scandinavian countries have the highest frequencies. When you look at lower latitudes and also other cultures, we see marked reduction in incidence of GCA. So let's go back to the large vessel story. One of my patients who's in her 80s with GCA has left subclavian and axillary stenosis, and she has the mirror image of this in her right arm. So how often does this occur in GCA? And I'm going to have you guess. Is it 25% of the time, 50%, 70%, 100%? It's a trick question. And the reason it's a trick question, it depends on how you look for it. So say you look for it only based on clinical grounds. Say you're identifying large vessel disease by the presence of bruits, asymmetric blood pressure, absent or reduced pulses. Then the yield is 20 to 30%. But say you believe, as some of us do, that large vessel disease is actually very common in GCA, much more common than the clinical perception would be. And then you do CTA or MR. Well, now the frequency of large vessel abnormalities goes up to 65 to 70%. Say you use PET. Well, there it's 85%. So how do we get to 100% post-mortem? If you did a post-mortem study on all people with GCA, how often would you find large vessel involvement? First, let's look at PET. So here by PET, a lot of data from Danny Blockmans in Belgium. Danny shows us in this picture increased fluorodeoxyglucose uptake in subclavian vessels, in the carotids, in the aorta. And when he does this in sequential patients with GCA, 85% have this pattern of uptake. 31% of patients with polymyalgia rheumatica do too, which has led Danny to comment that possible isolated PMR does not exist, but that this is always an underlying but clinically not dominant vasculitic process. And I think that's a very tenable but as yet unproven hypothesis, because we don't have post-mortem data on people with PMR, but we do on GCA. Now, this is a small but very instructive study. So post-mortem patients comes from a pathologist, not a rheumatologist, not a vascular medicine specialist. Garell Osberg did this at the end of her fellowship in Malmö, Sweden, 1972. This is a lost pearl in the medical literature, and you'll see why. Because Dr. Osberg wanted to know how often large vessel inflammation occurred in GCA, so she did an extensive dissection in consecutive patients. These are elderly patients, so they die. Average age is 74 at presentation, so it doesn't take many years after that for these people to come to post-mortem. And in Scandinavian countries, there's a culture that says almost everybody who dies should get a post-mortem. Because that's how we learn, that's how we advance the science. Unfortunately, that culture is more like ours these days, and fewer are done. But what she did is she did a dissection of the entire aorta in these patients, from the origin of the aorta all the way to the branch vessels going to the elbows and the knees. Big dissection. But more than that, she then cut sections every 2 centimeters along the way. And from that, she drew this diagram as a figure from her paper, and these lines of emphasis are where she found inflammatory changes within the vessels of these patients with GCA, one patient with Takayasu's, and the areas where you see cross marks are where the anatomy of the vessel was altered, here aneurysm and here occlusion. And the emphasis that I want to make is that 100% of patients had subclavian or innominate involvement, 93% carotid, 85% aortic involvement. The other important point here is some of these people were treated with traditional course doses of steroids for up to 7 years in some cases, and they still had active disease at the time of death, raising questions about whether or not we ever cure this disease, whether it ever goes into complete remission. So GCA, 100% of people have large vessel involvement, just as we've defined Takayasu's. The same or different. Emerging studies are beginning to tell us that these people also share the same genetic traits. The histopathology from these lesions is the same, and you should think about whether or not some of the differences in phenotype relate to young people getting a disease, old people getting the same disease, but the expression of that disease being a little different based upon perhaps the immune response when you're young versus the immune response when you're old, differences in tissue substrate when you're young compared to when you're old. So if we were to look at GCA and survival, we would recognize that in a population of patients with GCA, there's no difference in survival compared to the general population, except if you look at those people with thoracic aortic aneurysms, and they have a marked reduction in survival because 30 to 50% of them are going to dissect or rupture and experience a sudden death. So that raises issues for you as the care provider. Who do I screen for large vessel disease, particularly aortic aneurysms? And the answer to that's straightforward. It's everyone. Everyone should get screened. How should you screen them? Of course, history and physical. You're listening for bruits. You're looking for inequality of pulses and blood pressure in right versus left. And if you find any of that, you are absolutely obligated to do an imaging study. I think all of these people actually should be imaged. And we prefer MR because there's no risk of radiation exposure, and in the setting of normal renal function, it's an incredibly safe test. So what has changed in the treatment of GCA in recent years? Well, it's steroids, steroids, steroids. And a lot of the secondary agents are interesting. Some are beginning to show efficacy, but aspirin actually has been the most important breakthrough here. And in results from both Israel and in our own cohort here at the Cleveland Clinic, low-dose aspirin actually makes a very big difference in decreasing cranial ischemic events such as blindness and stroke. Anti-IL-6 is coming along, and you're going to see studies with tocilizumab in GCA soon. At this point, we'll also take a break and come back and consider some very dramatic breakthroughs that have occurred in ANCA-associated vasculitis and its treatment.